Hi, it's Jenny B, NSWOC. Today I want to talk about diabetic foot ulcers. So this is one of the first in my etiology series, so basically different wounds and the causes for them. Today I'm going to actually really review all the factors that I actually address with a brand new patient that does come in to clinic with one of these, because again, localized wound care is kind of really the last little piece to this. There's lots of other things that we have to address because again, we're not going to get healing if we're not addressing some of the other underlying problems that we can have with a DFU. I've also done a video on osteomyelitis, so that's when these ulcers do become more advanced, that it's good to review. Also, I'm going to do an additional video on offloading devices, one of the factors, key factors actually in healing these. So what is a diabetic foot ulcer? Well, it is a repetitive strike injury on an insensate foot. So meaning that they have lost sensation on the foot. How do we test for that? So number one, there's these little things called a monofilament. It's got this little plastic piece that, again, we'll actually do a test. On the back of them, it actually shows the different points on your foot you're going to do. I actually also do the heel as well as the midfoot, because again, the patient with this, they can have it anywhere on the foot, and also as well on the top of the foot that I would actually test to see. So the little test that I'm doing is I'm actually pushing on the monofilament and seeing it actually bend. What that does is it shows me if there is sensation in that area or not. Often people don't know that they've lost sensation, and that's why they end up with holes like this. It's the fact that they're walking on it, and again, they're putting pressure, and that pressure is concentrated usually in that area, and they're not knowing that they need to move their foot. So our bottom gets sore. We've been sitting on it, sitting on it for a long period of time. We will move it because we have sensation, or we can actually feel it, where most of these patients can't. So that's really the primary cause. It's the lack of sensation. Again, there's also lots of other different problems that come with that, such as foot deformities. So deformities happen over time. So the foot, we're going to pretend this is the foot. This is the top part is your dorsal aspect. The bottom aspect is your plantar aspect. So what happens over time with diabetes is the tendons, because you can see them much better in my hands, they atrophy or they tighten. And so what happens is it actually pulls up on the foot, and it can pull the toes up. Different things can actually happen when they can become hammer toes, very similar to this photo. This patient actually has Charcot-Marie tooth syndrome too, which causes all of them to do it. But again, this is actually very common in patients with diabetes, and so they end up with deformities on their toes and their feet because again, the tendons are pulled up, and then they're again causing this deformity. So then they end up with pressure in a certain area. So you'll see something like this. This is actually a very common location that I see, like on the great toe, that they're putting all their pressure, all their weight in that area. So sensation is one of the very first things that we're going to test. It's the very first thing that I talk about with the patient. The next thing I do talk about is diet, weight, and their BMI. So again, if they are diabetic, or not, we'll talk about that a bit in a second. The excess weight that they may be carrying can also contribute to the wound getting worse. Also, if they're quite heavy and their diet is quite poor, they're not usually getting nutritionally supporting the healing of the wound as well. So I do have a long conversation about what our actual Canada's food guide looks like, getting in good proteins and non-animal proteins if possible, as well as then the next is blood sugar management. If your blood sugars are very high or over 10, you're not going to have good healing. What happens is, and this is my favorite, my ortho's little analogy of it, so your white blood cells are there to help heal things. And what happens is if there's a lot of sugar in your blood, what happens is it's like your white blood cells, instead of going to work and do the work of actually healing, it's like they've been drinking, they've been on a bender, and they're all, oh yeah, let's get all this work done, and they can't. So again, blood sugar control is a really key piece, because again, we don't want little drunk worker white cells trying to actually heal something, because they're not going to be very effective. So blood sugar management is also a real key to it. If you have the opportunity to send your patients, or you are a patient that you could go to a diabetic education center, they can actually help manage your blood sugars and look at the medications that you're taking so that we can get a more optimal sugar control. What we also want to make sure that we're testing is for your HbA1c, or your hemoglobin A1c. So that's a blood sugar that tells us over a 3-month period how regulated your blood sugars are. If you have really high spikes and really low lows, you're going to get an elevated HbA1c. So if again we're getting good management, you're going to see a really good number. And so we like to keep that number under 7 for good wound healing. Again, but if it's not, then we really need to look at what changes can we do in diet and lifestyle, so exercise and whatnot, to be able to lower that. So one of the next pieces that I'm always discussing is vasculopathy, or again, if they are a smoker, and if that's the case, we do review smoking cessation therapy. The reason is because, again, if you're smoking and you do have one of these ulcers, again, you're going to cause some ischemic changes or hypoxia to the wound, because you're not going to get as much blood flow to there. Every cigarette that you smoke, it actually takes about an hour for your body to return to normal oxygenation. So again, someone that's smoking, every hour, they're really never getting a really great amount of oxygen to the wound. So again, all these factors really affect trying to heal this, because if the patient is quite overweight and not able to manage that, their blood sugars aren't managed, they're smoking, again, it really, the topical dressings and whatnot is not going to make great changes to this. The next really big piece is offloading. So again, these are areas of pressure, because there's often callus that builds around them, and that those areas of pressure, if we're not removing that pressure, you're just going to continue to have that repetitive strike injury. So offloading devices, I will talk about again in a different video, are also key to this, such as orthotics, different shoes, air casts, and even full total contact casts. So I'll go through some of those in an additional video, because again, without offloading, even if we fix all those other factors I talked about, you're still going to kind of come up against a brick wall and not get these healed. Lastly, then, does become wound care. So again, if I'm able to address all those other factors, actually wound care is quite simple. Often I end up using a gelling silver alginate, often silver cells, what we have available in our area, and Mesorb. I'm a big proponent of not putting foam on a foot. Now, I'll tell you why. Most people are wearing a shoe. They may be changing their dressing once a day. Sometimes they're doing it every 2 days, because that's what the wound care protocol is. Again, but the foam, they often make them become too wet, and what happens is the areas become too macerated. So in an area like this, or an area like this, what happens is the wounds become too wet. The foam is actually too occlusive. So it's one of those dressings. It's just my opinion. I know there's lots of others, and I'm sure lots of people use foam on feet, but I don't. I use Mesorb because it's going to provide more moisture, and it's going to absorb more than a foam in that area. Because again, if there's too much moisture, you'll never get it to epithelialize or get to grow new tissue. So that's really what I tend to use for it. There's lots of other things that I can try depending on if we've addressed all those other factors. But the primary thing, believe it or not, that will heal these is a total contact cast. So I will go through a little bit with that. But again, that's also going to come down to your negotiation skills. Some patients, it's really just not an ideal thing for them to be wearing a cast. Usually they're saying up to 12 weeks. I see most of them heal in about 4. So it's taking a month of their life where they're in a full cast and they sometimes can't drive, can't get around very well. So it is one of the other things that we do definitely know works. And we'll talk about some of the other devices they can have after. So again, I'm just going to show the different types that we get. So the other piece that happens quite often with them, and how I know that there's pressure, is because wherever there's pressure that builds, there's callus. So that callus also has to be reduced. So that should be done every 1 to 4 weeks, depending on how quickly that they are developing the callus, and how many of those first factors that we're actually able to address. So while they're sometimes addressing that, it's also how the frequency in which the callus will build up, and how much they're walking, how much they're moving. So if they're walking and out working 12 hours a day, that patient's probably going to need callus reduction on a more frequent basis than than someone that's, that's a little more sedentary, sitting at home, retired, watching TV and not doing as much, maybe just going to the bathroom in the kitchen. So again, we really try to base that on what the patient's activity is doing. So because if we don't reduce that callus, what happens, it's like having a stone in your shoe and you don't feel the stone because they're insensate. So then that can actually create these holes. That's what actually what most of them are from. I've pulled out tacks, I've pulled out nails, I've pulled out all kinds of things out of people's feet that they have no idea that were there, again, because of the lack of sensation. So again, these ones are sometimes a little more trickier to heal when in this location. Also, when you have 2 feet, offloading devices can also become difficult. So what we tend to do when there's 2 feet is we actually use offloading devices on the worst wound first, get it healed, and then we switch over to the other, because they can't tend to wear them on both feet at a time. The other thing we do consider with them is their gait. So if someone has broken hips or bad knees, sometimes they can't wear these offloading devices. So sometimes we get a lot of different factors that we can't fix them all at once. So we try to fix what we can. So if you're able to concentrate on those types of things, again, discussing diet and weight management, smoking cessation, if we're able to address the blood sugar control, make sure that they're having control, we're able to look at trying to offload the pressure in an area, and then provide local wound care and callus management. Those are really your main principles at managing a diabetic foot ulcer. Some areas have access to these services. Most NSWACs are able to provide that debridement, and it is covered under OHIP in most areas. So that's really where you want your NSWACs out there managing this. So hopefully you found that helpful. If there's any other questions, please put them in the comments and I'll be happy to address them. As I said, I will review offloading in the next video. And don't forget, the best wound is a closed one.